Okay, so I'm Della Roberts, and I'm a clinical nurse specialist, as it says there in the end-of-life care program in Fraser Health, and a co-investigator in iPANEL. And I've actually had an interest in working with people with COPD since I did my master's way back in the, I finished in the mid-'80s. And I focused on people living with chronic illness, and my specific population I was most interested in were people with COPD, and then I went on to work in a respiratory rehab clinic, and that's actually how I came to palliative care. So this is one of my particular loves, I guess, and interests. So I was pleased to be able to have a discussion today, and I'm going to briefly just talk a little bit about iPANEL and then explore the lived experience of people with advanced COPD and, what about the palliative approach? What does that mean? Explore nursing accountabilities and key practice supports. So here we are, our iPANEL initiative for a palliative approach in nursing, and this is a Michael Smith-funded research collaborative with researchers, academic researchers, administrators, and practice leads, particularly interested in people who are living with chronic advancing illness that they will die from, and looking at how a palliative approach could benefit those people, and exploring that from different perspectives in relation to healthcare delivery. So, one of the most prevalent of the life-limiting conditions is actually COPD. Many people die from COPD, and I was interested when I was looking at some of the literature and the support study way back from 1996, talking about that within 2 years of an admission for an acute COPD exacerbation, 50% of people will die. And I thought, gosh, it's a lot harder to get into hospital now than it was in 1996. So I would say that's probably still a pretty confident number, imagining how much at risk somebody is if they actually were having to be hospitalized with COPD. Yet, in practice, and for the public, even people that have COPD, the awareness is that COPD actually is a life-limiting illness, that it's progressive, and people will die from it or can die from it, is not well often understood, talked about, even though in 2008, BC put together a COPD services framework that actually is very well done and grounded, and one of the recommendations is that that component should be taught. But of course, it can be difficult to talk to people that have a disease that they will die from about the progression of that. So that can be challenging to us as providers to include that in our conversations, and I'll talk a little bit more about that. So COPD is a label for airflow obstructive disease, really related to emphysema and chronic bronchitis. Many people often may have a reversible component, an asthmatic component as well, to their disease. And as the disease advances, people have a very high symptom burden. Breathlessness is the most challenging of those symptoms, I would say, or can be. But related to the chronic bronchitis, people often have a cough. Energy loss and fatigue is a profound symptom as the disease progresses, just because of the work of breathing. And normally, we don't have any effort to breathe. We don't even think about it. But people, as their COPD progresses, they're actually working when they're breathing. So anxiety is a component often of the disease, and many people, some people in advanced disease will have this panicky time. Fears and depression can be prevalent as the disease progresses. When I did my master's, I actually did a study, interviewed families, the person with COPD and their family experience, and they talked about what it was like as a family to live with COPD, and these are some of the descriptions that they talked about. One was just this knowing that COPD threatens breath, and that breath is the essence of life. If you're not breathing, you're not living. And that they live with a tremendous uncertainty day to day because how will their symptoms be, and depending on how triggered their breathlessness is, that influences their ability to be active. So both they live with this uncertainty day to day. It's very hard to plan in the future because they don't know how they'll be that day, and also this future uncertainty as it is a progressive disease. Families also describe living in as the disease advances, having this kind of disease-dictated family life where they have to protect breathing. So thinking about where are we going, is there stairs there, how close to the door is that, do the people there wear perfume, that they have, the families tends to live more in the present time than plan too much in the future, and they have a limited tank of gas. So they live with this in this energy economy. So if they're going to do things as a family, it's dictated by the amount of energy that the person with COPD has, and of course it has profound impact on roles as chronic diseases do as they advance. So there's an isolating component to advancing COPD because of this protecting of breathing. We can think of that more within the environment, but I was struck by their descriptions of some of the emotional restrictions that are important, both for joyful events and actually for worries. So even sometimes as disease advances, having grandchildren over and just the anticipation of that can be enough to trigger shortness of breath. So COPD, as it advances, really has a profound impact on the lived experience of the patients and their families. This study, there was a couple of studies in relation to just comparing people with end-stage lung cancer, where there's a more predominant from palliative care awareness that they would need dimensions of palliative care, and comparing that with end-stage COPD. And the highlights of these studies, they highlighted that people living with COPD, they really had, in the measures that they had in relation to quality of life scores, that there was more profound effect on the quality of life scores from all different components of functioning, increased depression measures, and less ability for activities of daily living and activity for a lot more prolonged time. So similar symptom burden as disease was advanced, but that people with COPD lived with that for a longer time, very significantly, than somebody with end-stage lung cancer. Another study that interviewed people with moderate to severe COPD, and that's often determined by their forced expiratory volume, is often a measure of the degree of COPD. So they studied these people with moderate to severe disease and were somewhat surprised at how often people didn't even know what diagnosis they had, what was wrong with their breathing. Most of these people were unaware of the progressive nature of it, that hadn't been shared with them, and few were aware that they could actually die from COPD. A very common concern of this group was, even though they hadn't been told these things, they talked about a fear of dying in a suffocating or breathless manner. And when asked, none of this cohort had discussed these fears with healthcare providers. And this is very similar to a lot of the advanced care planning literature about people with chronic disease, that although they have fears, unless there's an invitation from healthcare providers, that may not be anything that they bring forward. And of course, within the group, there were different preferences for discussing the likely illness course, some people wanting that, some people not wanting that. So, and again, that's consistent with other literature of people with chronic disease. So fundamentally, people with advancing COPD have profound disease and have need for all dimensions of care from palliative care. But what actually happens in practice? Often there's a question, and we can pose the question today, who would benefit from a palliative approach? And oftentimes the question that's asked in practice is who would benefit from palliative care? This is becoming, I think, a more commonly referred to question, and you might have heard it in other webinars that we've had, even this surprise question. Would you be surprised if this person were to die in the next 6 to 12 months? It's kind of a trigger for supportive or palliative care from the gold standards framework in the UK, along with if people describe that they identified or verbalized they have a choice for that, or that there's clinical indicators of real advanced disease. I was interested to read this article by Small and Gardner, who've done a fair amount of work with people with COPD, and they really were challenging the surprise question. They were saying, given the huge variation in COPD prognostication for the same clinical status, they had some real concerns that even the surprise question was really too narrow and really talking about people in very advanced disease rather than advocating for what they called continuous palliation as a component of ongoing care of what we're talking about in iPANEL around a palliative approach. And if you think about the trajectory of somebody with organ failure, like people with COPD or heart failure, where one of these exacerbations they're going to die from, but you don't know which one. And as I talked about at the beginning of the session, if they have an exacerbation, we know that 50% of people, or they were hospitalized, 50% of people will probably die within 2 years. But if people are looking for when is it advanced enough, we know that many people with COPD don't have this prognostic clarity, and so aren't really identified as on the palliative care road. And there is still a lot in the literature about waiting for that sign. So the lens of a palliative approach is actually in line to what Small and Gardner were saying, is this continuous palliation, this notion of taking the principles and applying them along the trajectory and not aligning that so closely with prognosis, but more with needs and awareness that it's required. So if you look at the prognostic indicators in the gold standards framework, they are helpful because certainly these people for sure need a palliative approach because they're really having recent hospitalizations, great dependency, they're even losing their nutritional status and weight loss generally. And then when they talk about people with COPD specifically, both the gold standards and the BC COPD service framework, they kind of talk about people with real advanced disease, and for sure those people as nurses or healthcare providers, anybody that fulfills these criteria should certainly have a palliative approach embedded. And I guess, but it's not only these people. It's not only people that have these prognostic indicators. And sometimes even these folks aren't getting a palliative care or a palliative approach embedded in their care. I think we're hearing more and more now about frailty and recognizing frailty rather than disease prognostication. And Here's an article in relation to palliative care for the frail older adults, where they look at loss of strength, weight loss, low levels of activity, poor endurance, fatigue, poor slowed performance. I think those are also very helpful indicators around as another way to get at thinking of people that are really at risk and really are high priorities for a palliative care, a palliative approach. But I think when we're thinking about a palliative lens for people with COPD, it's kind of this acknowledgement of this, that they are living with this duality. They're living in a state of surviving exacerbation, surviving their periods of breathlessness, and going on to live as this awareness of limited mortality, either very aware of it or subtly aware of it. And that doesn't match our healthcare system, which often has an either-or focus. Either you're fighting or you're dying. So either you're fighting to get through this or you're comfort measures and you're in your dying time. And I thought this article by Bailey and their group, where they talk about this duality, their quote that really most people are living as well as possible, acknowledging that their time's limited, and that is their lived reality. So the palliative lens is then this integration of chronic disease management and palliative principles. So what does that mean for people with COPD? Well, it is founded on chronic disease management, and I'm amazed, actually, like the study reflected, how many people are actually given very, very little information to self-manage, to understand their disease and trajectory. BC has done a good job with their practice support initiative around COPD, with engaging GPs and GPs' offices. There's Breathe Well programs that have been set up, and I think that work that's happened over the last few years has been very, very strong in relation to trying to have a better integration in care around working with people with COPD to actually anticipate, have red flags, exacerbation plans. One of the areas I think that's really important, and is something that we often don't think of, those of us that come from more traditional palliative care, is the importance of maintaining strength ongoingly. This disease management is embedded, integrated all along the way. And for people with COPD, even with very advanced disease, maintenance of strength is really important and can make a huge difference in their symptom management, as minimal as just doing some slow-paced walking and some exercises in the chair. And those are important things for us to embed, for all of us to be embedding, whichever way we come across this. And then fundamentals of breath control. And the integration of a palliative approach with chronic disease management is really the acknowledgement of the life-limiting nature of the illness. So I had the opportunity to speak with some of the folks from the Breathe Well program in Fraser Health a while ago, and they were bringing forward this group and saying, sometimes we feel like we've missed the mark because somebody goes in and dies that's been on our Breathe Well program, and we're surprised by it in one way, but yet in another we knew that they had advanced disease. So in care, this notion about acknowledging the life-limiting nature of the disease and talking about disease advancement with a family focus is a component of the integration of a palliative lens. So in goals of care conversations, we're really exploring and addressing worries and fears, asking questions specifically about that. Impeccable symptom assessment and management. And then for us, specifically as nurses, recognizing that this person needs care across the sector. So that's one of the strengths of the Breathe Well program, is it's trying to embed strategies across sector by having a common framework. And then actually preparing for transitions, preparing for death and dying, having discussions about imagining that and what's important, and actually having the will and the strength to go there in conversations. So the framework from 2008 has this as one of the core recommendations about open communication, advanced care planning. When you think about what does that mean for nursing accountabilities? And foundationally, it's as starting with these questions. In the event you're too sick to speak for yourself, who would you want to speak for you? And have you spoken with this person about what's important to you? That is a question that nurses on admission to an acute medical unit can ask in home health, case management, long-term care. These are becoming more embedded in practice, but it has been less clear what the nursing accountabilities for this are. What do you understand about your illness and what to expect? What information do you have? I've obviously thought of something else. I've got just what. What's most important to you? What's of greatest concern? What are you most fearful of? So these are foundational questions that are important for anybody with life-limiting illness, but very appropriate for people with COPD, and for nurses using sentinel events as openings to these conversations. So we were working on another project, and somebody was talking about frequent flyers. So on their unit, some people that had been in and out with COPD exacerbation, and actually, so they know them over time, and actually talking about that and said, being able to say something like, oh, if we were really worried about you, what do you think, what were you thinking when that happened? If things don't go so well the next time, talking about their family. Physicians are very earmarked in relation to the COPD service framework, and obviously have a key accountability, but it is actually a key accountability of nurses as well too. And when you think about these folks with COPD, they actually might be managed by their GP and respirologist, potentially coming to hospital at times, and then they may not have home care nurses working with them. They may have a case manager and have some home support and actually see a registered nurse quite infrequently. So when there is contact, it's actually pretty valuable time for a nurse. Symptom burden and symptom distress screening is obviously a foundation to palliative approach, and particularly for people with COPD, doing a very good symptom assessment, fatigue assessment, sleep and cough. And a number of places are now using a more broad symptom assessment screening form, like the Edmonton Symptom Assessment Score or Screening Tool, the revised one, which has the common symptoms, a very concrete strategy that can be embedded in practice. For people with COPD, also screening for weight loss and sleep issues is often a real indicator of symptoms not well managed. One of the things I think that's key, and again that nursing has a key role in, is identifying people that do have a more profound symptom burden or impact on their lifestyle, and figuring out how to increase accessibility of these folks to the nurse and the physician, and if they have a respiratory therapist involved. Health teaching, I touched on it before, but I often wonder what's happened to our nursing accountabilities with health teaching, and clarifying what actually are our nursing accountabilities around health teaching. And certainly with this population, it's fundamental to explore that, and and whether a nurse has the competencies in health teaching for somebody with COPD to do a basic assessment of just how they're managing, so that they can draw in and get people to a resource that they can gather more information from. Nurses also have an important role of advocacy around symptom distress. And it's interesting, the COPD service framework, again, talks about people in end-stage COPD, and, you know, are clear that along with trying to alleviate symptoms and the disease management therapies, that we have to use other kind of approaches like opioids and adjuvants during an exacerbation. There is still a hesitancy, I would say, in practice for people with a COPD around actually implementing this and addressing their symptom distress. And I think this is where nurses have a huge role in advocacy, in being a patient's voice and bringing forward the impact and the symptom distress so that it can be highlighted what is the impact, so that then the distress can be addressed. Opioids in relation to dyspnea have been well documented for more than 20 years with a variety of populations, and COPD being one. So I think it's so important to be able to ask people if they're breathless, when they're breathless, and I think I might have hidden the slides about the typical dyspnea screen in the chronic disease world with COPD is somebody so short of breath that they're housebound. That becomes the lowest kind of denominator in relation to the dyspnea scale. And of course, in palliative care, we're more used to using from 0 to 10. But it needs to be looked at in relation to all aspects of so with activity, at rest, so that there's a good description of it. And there still is a strong advocacy role for nurses around opioid use with people with COPD. The Canadian Thoracic Society has, in 2011, put guidelines together, and I have a reference for them at the end. And they highlight that there's no good evidence for routine use of anxiolytics or antidepressants as a dyspnea management strategy. For depression, for anxiety specifically, those can be important tools. But when they're used for dyspnea management, it is not really the effective approach. And I think for us as nurses, when we see routine use of Ativan for somebody with dyspnea and they don't have an opioid, that's typically a trigger that the person has symptom distress that could be better managed. And another accountability is for nurses to have confidence in using opioids, specifically, for example, in a population like people with COPD. So as health educators for nurses, the importance of teaching and building nursing confidence in how to use opioids and opioid-induced sedation scales, so people understand that sedation happens prior to respiratory depression and can feel confident in using opioids. I've just included in the slides a traditional starting doses for opioids, and this is something that we'd be more familiar with from the palliative care lens, but even if we look from the chronic disease lens, and this is from the Canadian Thoracic Clinical Practice Guidelines in 2011, they take a very cautious approach in relation to starting opioids with people with advanced COPD, and I think this is something that we should be more familiar with, because it's, again, embedding these principles and this learning each other's language to embed a palliative approach. So they would, from a respirologist perspective, they would be more comfortable with starting somebody and titrating really over a month, starting with really little doses of short-acting like 0.5 milligrams twice a day for 2 days, and then going to, and this is of morphine, and then going Q4H, and then going up much more slowly. So that is a much more cautious approach than we are more familiar with from a traditional palliative care approach, and this is probably in relation to nursing advocacy and coming alongside and being very cautious, because one of the things with people with COPD that they're so concerned about is actually opioid-associated constipation. And so actually starting in this really slow and titrated way, we can have a much better titration too of the laxatives and avoid opioid-induced constipation when people that are so limited in their breath. So nurses have accountability around competency with that. And then finally, I just wanted to highlight the practice supports that are needed for embedding a palliative lens for people with COPD, and these are not any different than thinking about that for any person with life-limiting illness. And we have another iPANEL initiative around nursing care delivery for a palliative approach that will be having some results coming out later this winter. But the notion is that these practice supports that we've alluded to actually have to be embedded in care processes. So in relation to the person with COPD that comes into a medical unit, how can aspects of this be embedded in the care process in the unit that serves many people with all kinds of different illnesses? So these disease-specific approaches are often lost in these generalized areas that look after people with multiple illnesses. So these principles that are important for somebody with COPD, when we try and embed them in an acute medical unit and embed them in care processes, it is important that it's applicable to a broader population often. There may be some specifics that can be flagged, for example, fatigue and COPD with a person with advancing COPD. But the question that I had posed at the beginning about who would be your substitute decision maker, that's a generalist question. What are you most concerned about? What do you understand about your illness? Those are general questions that can be embedded in care processes. And by doing that, it gets at this issue of permission. In some care settings, and certainly in acute medical units, and I would say, probably less so in home care, but in residential care, acute medical units, the notion of nursing permission to actually have conversations around goals of care require some integration into the system to be clear that there is permission for conversations. And strategies like the medical orders for scope of treatment in Fraser Health, which is an initiative around goals of care, provides some common language and some structures embedded in care process that give permission. And I think that actually that's a big issue around this area, even around health information for people with COPD. So clear accountabilities and then system supports. Breathe Well, that's an example of a broad system support for people with advancing COPD that has been initiated. It has been heavily strong on the chronic disease management component, which is fabulous, and there's the opportunity to better embed integration of advancing disease and acknowledging that these people, especially when they're referred to Breathe Well in the province, those people have had a couple of hospitalizations for acute exacerbation, so there's certainly people at risk of dying. Leadership support for palliative approach generally, education specifically, and I think nursing confidence and competence in certain areas around foundational pieces. And I do think symptom management for the person with COPD and opioid competency is important education across practice areas, along with competencies around goals of care conversations and the confidence and competence in bringing that forward in a collaborative care planning way so that the team, including physicians, can take action on that. And that, of course, all of this is supported by sound practice tools. So that, I think, is an overview of the application of a palliative lens to people with COPD, building on many of the discussions and the previous webinars, but looking specifically at the person with COPD. These are a few references of that I've drawn on in the presentation, and also that a couple that look more broadly at this pairing of self-management and with palliative care. The Bailey article, I think, is a really interesting one. And of course, one of the things I didn't talk about is most people don't just have COPD. You know, most people actually have multiple comorbidities that also need to be considered. What are they monitoring? You know, they might have congestive heart failure as well, so they're monitoring weight. But I think it is something as far as nursing care delivery or healthcare delivery systems that really has to be explored more, and I think BC hasn't been as out of the gate as some of the other provinces in relation to telehealth. One of the things I also didn't mention is also because COPD is often related to smoking, that sometimes people that have COPD, you have to be aware of what other issues are they dealing with in relation to smoking in their environment, other people smoking in their house, other potential social factors that might be an influence. So it's important in relation to, for any population that has an illness that's progressive and advancing, is different people have different desires for health information and for understanding what might be expected down the road. But I think, for example, still doing really good symptom assessment, asking people what they're worried about, what their worries are, or their fears. Those are opening kinds of questions that actually don't have an agenda behind them. And I think one of the things that I think can be helpful too is to just ask if there's kind of acknowledge that this might be difficult for discussions with his family. And if there's, would he appreciate support in relation to that? Sometimes, and you know, palliative care is main intervention, so from a palliative approach is a family meeting. So the notion of actually having family meetings and with the GP, or so that there can actually be, the family can be together and hear information and share information, and it only will be shared what's comfortable within the family. But a family meeting with a GP or with another healthcare provider is often a really helpful way when there are just different perspectives within the family. So the other kind of folks that can be helpful, I think, are like through Breathe Well, you'd have access to this home health social worker, and the notion about having some family conversation, and that's whatever community this person lives within, that's also where I think, as far as ideas or suggestions, that's where a palliative care clinician or whatever often can provide some ideas and some guidance too, because again, when you think about these two, chronic disease management and palliative competencies, oftentimes in palliative care, this is not actually unusual for any disease to have people have different perspectives within the family, or maybe have some challenges sharing that within the family. One of the things that I found very interesting when I was doing my research was the notion about what is okay within the family versus for the individual, and that's also been my experience over my time in practice. But there is a family reality that's held, and sometimes people will, what they say to us individually, as we all know, may not be what they will bring to their family. So I think one of the challenges for nursing accountabilities for people in acute medical units, residential care, and home health is, of those settings, probably home health case managers have the ability to integrate into their practice specific tools to specific disease populations. And in programs like Breathe Well, iPANEL has been kind of focusing on generalist practice areas, and I think one of the challenges is thinking about, in these generalist practice areas, what are the practice supports that can be doable for nurses in those roles. And just reflecting on my own experience when I worked with something like Breathe Well, when I worked in the respiratory rehabilitation clinic or was in a one-on-one situation with a little bit more, with a specialized population. But I know that works with a generalized population as well.
Is there much, I'll use the word frank, talk about the fact that these are life-limiting illnesses? Is it more about promoting the living well and that whole business of thriving or surviving and thriving through symptoms, or do you think it spans the broader range of recognizing this is a life-limiting illness?
I know that just speaking from my experience in Fraser Health, the respiratory rehab programs were pretty early adopters of advanced care planning sessions. And I think the notions about advanced care planning have become more embedded. I think for all of us that work with people with advancing illness, there's looking at talking about disease advancement can be challenging, expecting a disease advancement. So I think that whole notion about I think the respiratory rehab centers have done a good job in kind of introducing advanced care planning in the case of things changing. I think Breathe Well, I think using sentinel events of hospitalizations and times when people have had an exacerbation for people with COPD is a real opening.